All right, excellent. Welcome everyone to another EBFA webinar sponsored by Naboso. We are going to take an exploration around mechanoception, foot perception, and the neuropathic patient or client. So depending if you are a health professional, I know there's some podiatrists that are logged on or joining us. If you're a physical therapist, if you're a trainer, coach, Pilates, we love everyone and how we can work together to help these individuals who are living with neuropathy. Again, this is recorded, so if for some reason you get disconnected or you want to hear it again or you want to share it with someone, it is recorded. Everyone will have access to that by tomorrow, and you will get an email for that as well. So make sure you look for that. After we go through the webinar, we will have some time for some questions. So if you have those, you can type those in as you think about it in the chat or the Q&A. We'll make sure that we get to those. Otherwise, we're going to get started. So my name is Dr. Splichal. I am a functional podiatrist, human movement specialist, founder of EBFA Global. So I write a majority of the education through EBFA Global. If you want to learn more about our online and in-person trainings, which have started again, very excited for that, all around the world, please go to ebfaglobal.com, and that will guide you to all of our education and our YouTube channel. I've written the book called Barefoot Strong, which is available globally on Amazon, all the Amazons. And I am the founder of Naboso, which we will be referencing throughout this because, of course, we're going to be speaking about mechanoception. If you want to follow me or Naboso on Instagram, you can, of course, see that on the lower left. Okay, so when it comes to our neuropathic patients or clients, we want to ask ourselves, are we doing all that we can to help these individuals? Now, as a podiatrist, initially when I started to see patients with neuropathy, it would be, routine foot care. Let me do a, 6-month or annual foot check where I check pulses and skin, assessing the nerves to see, okay, do they have 2-point discrimination, vibratory discrimination, things like that, make sure that the nails are cut. And then that's kind of it. In the US, they do get a pair of shoes with the plastisode inserts covered by insurance, 1 pair a year. So that's kind of where, as a podiatrist, I typically thought about the neuropathic patient or client. However, when I think of it as a movement specialist, I actually think about, well, no, there's more that I could be offering this individual that has to do with the day-to-day reality of living with neuropathy. I'm not even talking about painful neuropathy. I'm talking about balance and numbness and a fear of falling and, this pending loss of independence because of them being scared that they're going to fall. So as a podiatrist or a movement specialist, can we offer more to these individuals to help them continue to support and put effort towards movement longevity? Peripheral neuropathy and a lot of chronic neurological conditions are really quality of life issues that they're not medical emergencies. They are, oftentimes not a lot of attention paid to them toward these individuals in these conditions, because again, they're just chronic, where we want to be thinking about what can we do for the quality of life in these individuals. So what I want to do, especially for those that may not be podiatrists or fully familiar with neuropathy, I'm going to establish some baselines so that we're all on the same page. Of course, if you're a podiatrist, just kind of hear me out for a little bit on this. So when we're thinking about peripheral neuropathies, this is where we are experiencing damage to the peripheral nerves, right? The nerves that are farthest away from our central nervous system or our spinal cord. Obviously, the tips of the fingers and the tips of the toes. And this damage is oftentimes inflammation. It might be free radicals. It might be toxic. So in the case of chemo-induced neuropathy, it is a toxicity to the chemo that is damaging these peripheral nerves. Typically in the case of diabetes, you're getting free radical associated. And then in more like a small nerve or some of the idiopathic neuropathies, you are experiencing this inflammation, this autoimmune response against the peripheral nerves. So what this is often leading to is going to be pain, stabbing, pains, burning. They might also experience tingling and numbness. So we're going to talk about the different types of symptoms that you might experience with neuropathy. And then a lot of this neuropathy eventually starts to affect the muscles and the integrity of the muscular coordination of the foot. So we're thinking of, there's this broken signal, this disruption. Sometimes there's a compromise to the microcirculation to the nerves. So then you start to get nerves kind of dying off because they're not getting sufficient oxygen and nutrients to support themselves. They start to get this missignaling, which is often very common in neuritises. Neuritis is a little bit different than peripheral neuropathy. So it's a more inflamed, acutely inflamed nerve that could be from, I've actually seen it with COVID and post-COVID vaccines. I've treated some patients who have experienced peripheral neuritises from that. And it's really part of that inflammatory storm that is kind of attacking or interfering with those peripheral nerve signals, okay? Now, a lot of these neuropathies, again, when you're seeing them in your clients or in patients, majority that people will think about is going to be diabetic. When you say peripheral neuropathy to someone within the health space, first type that they're going to think about, again, is going to be the diabetic neuropathy. Diabetic neuropathy, you can see in both type 1 and type 2. Diabetes, a little bit more prevalent in type 2 diabetes, in autoimmune. So this is where you're going to see small nerve neuropathies, obviously Guillain-Barré. So that's where COVID kind of came, brought Guillain-Barré into the media again around some of the vaccines creating Guillain-Barré-like syndromes, which are kind of these inflammatory responses. Some of the rheumatoid arthritises can experience it. I've seen it in Raynaud's as well. You might see it with nutritional deficiencies, chemo-induced peripheral neuropathy, again, increasing in prevalence, HIV and AIDS. Only reason why I mentioned that is I trained in New York City, and when I was going through school, there was a higher prevalence of HIV and AIDS, and also being in an urban setting, that I actually did HIV neuropathy research as part of my medical training. I had a keen interest in that, and then idiopathic neuropathy as well. Now, when we typically hear the words peripheral neuropathy, and again, you might think about diabetic or chemo-induced, MS-related, is that a lot of people may think about, again, numbness, tingling, can't feel their feet. So you're talking about sensory nerves. And a lot of peripheral neuropathies are sensory-based. Actually, a majority of them are sensory neuropathies. Certain ones are motor neuropathies. Charcot-Marie-Tooth is actually a combination of sensory and motor neuropathy. Now, why I mention this emphasis around sensory versus motor is that if you have someone with a sensory neuropathy, the muscles have the capacity to respond to strengthening the foot muscles. So when I recommend short foot exercise and barefoot training to a sensory neuropathic client or patient, it's because the muscles of their foot are still responding, and I need them to build that sufficient foot strength so they have balance and don't fall to offset the sensory or the lack of sensation of their feet. Okay, so I hope that makes sense. So again, a majority of the neuropathies that we will encounter as movement specialists, we'll just put as movement specialists, is going to be sensory based. So even though that client or patient can't feel their feet, they have the capacity to strengthen the foot muscles because they don't have a motor neuropathy. Now, the longer that you have sensory neuropathy, 10 years, etc., you start to experience these muscle weaknesses as a result. And then that's where you start to get motor effects, meaning cline of the digits. You start to get this cavus pattern in the foot. Some people will start to get some foot drop, muscle wasting, but that's not really a true motor neuropathy. It is the sequelae of having advanced sensory neuropathy. Okay, so I just want to kind of differentiate and distinguish that. Now, the autonomic neuropathy, really important to appreciate as well. This is also in, let's say, a diabetic with uncontrolled blood sugar and, high A1C, who has, extensive peripheral neuropathy, peripheral sensory neuropathy, most likely has some component of an autonomic neuropathy. Now, in the foot and the ankle, autonomic neuropathies present as poor sweating characteristics, thinning of the skin. They might lose the hair on the lower leg, really brittle skin. So you're thinking of whatever the autonomic nervous system controls is going to be, of course, sweating, vasodilation, vasoconstriction, which affects the skin. So skin perfusion, right, is greatly affected. Autonomic neuropathy combined with a sensory neuropathy can start to affect the health of the nerves even further, because again, that vasoconstriction dilation response of the autonomic sympathetic nervous system will further affect the peripheral nervous system from a sensory motor perspective. Okay, this is where you could also say that someone has a hard time controlling like the heart rate. If they work out and they have autonomic neuropathy, they might have poor temperature body regulation because of the autonomic nervous system being affected. So that's where, more from a fitness perspective, you do want to appreciate that autonomic response. Okay, so we have types of neuropathy. We have sensory motor autonomic, which is another classification. Now we have to briefly speak about the symptoms that the client or patient might be experiencing. And this is where you can differentiate these into positive or negative symptoms. Now, when I say positive, that doesn't mean, good. Those are good symptoms. That just means that there is a uptick in the stimulation that the individual is experiencing, where a negative symptom would almost be like a void of a sensation. Okay, so these are some of the most common ones. Positive symptoms that your client or patient may be complaining about is burning, radiating, sharp, splashes of water on the feet, feeling like there's heat on part of the foot or along where that nerve runs, sensitivity to textures, not Naboso texture, but more like the shoes are continuously feeling weird under their feet. The socks are abrasive. And, some of my patients that have various neuropathies would come in with literally 10 pairs of shoes and 10 socks and insoles and say, this feels comfortable. And then I wear it for 2 days and now I can't. It's just like my feet hurt so bad. And then so they'll try another type of insole and then another type of shoe. And they continuously start to chase these shoes to find what is comfortable to avoid, burning at the ball of the foot or something like that. Very much a common neuropathic presentation for individuals to say that. Positive side. Negative symptoms is going to be numbness and tingling, right? So we can see that if we look at these different symptoms, when someone says, I have neuropathy and I have whatever type of neuropathy, I have chemo-induced neuropathy, sometimes people assume that's going to mean that they have numbness, or people will assume that means that they have pain. That's not true. And we want to make sure that we are really distinguishing and asking the right questions with these patients or clients is, okay, if they have the neuropathy, what are your symptoms, right? I have pain. can you differentiate that pain, right? Because sometimes patients will say, I have pain, and then they actually say it's tingling, and the tingling is more of this negative symptom or this lack of sensation symptom, okay? Now, when you are thinking about neuropathic treatments or neuropathy treatments, this is where a little bit of my frustration in the Western medical system, especially in the US, will say, patient has neuropathy. Without even asking the type of symptoms, they're put on these neuropathic medications such as gabapentin, Neurontins. These are in the US, some of the generic and the trade names, Lyrica, pregabalin, some of the amitriptyline. So you're looking at these GABA inhibitor type medications that are designed to treat only positive symptoms, only positive symptoms. If that patient or that client says that I don't have any painful symptoms, my only symptoms with my neuropathy is that I have numbness and tingling in my toes. That's it, right? So I'm having a hard time feeling the ground. That's my symptoms. I don't have any pain related to my neuropathy. And then I ask them their medications, and they say that they're on gabapentin, Lyrica, something like that. And I ask if they've ever had painful symptoms. And they say, no, I've never had painful neuropathy. My only symptoms is numbness, right? Then part of me is like, well, why are you on medications with so many side effects when those medications are designed to treat positive symptoms? They work by blocking the pain pathway for that individual. So on this numbness and the tingling side could then be, well, what are you doing about the fact that you have numbness in your feet? Nothing. There's nothing, right? I'm giving them comfortable shoes, but what are we doing to eventually say, well, what is the result of these different symptoms? They're chronic, right? So if I have positive symptoms such as burning, stabbing, splashes of heat on my feet, right? Chronically, I've to live with this every day. As a professional, what can I do to help that patient? Medication, right? Glucose control or control inflammation, but to help that individual from a quality of life is really where those medications come in, okay? From the numbness and the tingling, chronically, long-term, someone who's experiencing numbness, what can I do for them is I understand that if they can't feel their feet, that's going to contribute to fear of falling, loss of balance, instability, lack of independence, right? Gabapentin's not going to change that side of neuropathy. That's the whole point of this webinar, to say is, what else can we offer those neuropathic patients and clients on the negative symptom side of it, which is numbness and tingling, chronically, to support their quality of life? This is where we're starting to look at then movement. What are the movement considerations for that neuropathic client or patient? What are we doing to help them, right? So here's a few stats. Again, I do apologize that some of these are US based, but there are 20 million people in the United States that are living with neuropathies, all types of neuropathies. In the US, 1 in 4 Americans will be diagnosed with cancer, which those are awful, awful statistics. That 1 in 4 Americans are going to be diagnosed with cancer. And the rate of experiencing chemo-induced neuropathy is increasing. And most oncologists don't have the skill set, or it's not a priority for them to be thinking about something, quality of life movement, when they just want to make sure that this patient is cancer-free. So then they're left, they might be cancer-free, but then they're left with this positive or negative symptomatic neuropathy that's affecting their quality of life, and chronically, long-term. And then as far as MS, 1 in 4 MS patients or individuals will eventually experience neuropathy. So those are some pretty decent statistics. And of course, peripheral neuropathy is a significant contributor to fall risk for those with diabetic neuropathy. A diabetic neuropathic client or individual has a 15 times greater fall risk. So again, someone with diabetic neuropathy is a 15 times greater fall risk than someone the same age diagnosed with neuropathy, but doesn't have diagnosed with diabetes, but not experiencing neuropathy. That is huge, right? Then it also shows that there is a psychological factor that influences people's ability to maintain balance and prevent a fall. And this psychological component of movement confidence, balance confidence, knowing that that is a contributor to fall risk is something that we want to make sure that we can address as movement specialists, podiatrists, etc. So this was interesting. For every unit increase in balance confidence, there was an associated 9% decrease in risk of falling, right? Really, really interesting. So what can we do to improve movement confidence in these individuals? Now, in the case of movement therapy, movement exercises, doing balance exercises to prevent falls, a lot of these patients and clients are always told, if you have neuropathy, don't ever take your shoes off, right? You got diabetes and neuropathy, you must wear shoes. You wake up, put your shoes on. You go to bed, okay, then you can take your shoes off, right? That's literally how I learned it in podiatry school, which in my opinion, doesn't make sense when the footwear, we're going to go into it, the footwear is a contributor to the sensory disconnect of how these patients and these individuals feel their feet. So they are scared. One, they're scared of falling, but now they're scared to take their shoes off because their doctors keep telling them, no, don't take your shoes off because you might step on something and then it gets infected and then you get an amputation, right? So to treat in fear is what I try to not do. I try to treat based off of empowerment and education to a patient versus scaring the patient so much to make them compliant, right? Two different, slightly different philosophies. So movement accuracy and fall reduction, right? So we want our patients and clients to move accurately. We want them to move confidently. And we, of course, need to reduce falls. And that is going to correlate off of body and foot perception. So we want these individuals to say, I can feel my feet again, right? I can feel the ground. So when we think about our ability to maintain our balance and to feel confident when we are walking is based off of our ability to feel the ground, to connect with the ground, right? The foot and ankle plays such a critical role in how we maintain balance, posture, and gait. And of the 4 input systems, eyes, ears, joints, and skin, the joints being really the ankle and the bottom of the foot, those 2 aspects of how we maintain balance, posture, and gait is really what we want to be accessing as movement specialists and as podiatrists. So if we look at the foot and the ankle, we have both proprioceptors and mechanoceptors. Proprioception is going to be based off of our proprioceptors, which are muscle spindles and GTOs. So these length tension triggers of the joint capsule, the muscle tendon junction, the ligaments, they are triggered when we start to wobble the foot and the ankle. And that's essentially helping the nervous system create a perception of joint position, right? It's called joint position sense. So as I start to move my foot and ankle, like in like a wobble board would do, or a Bosu, doesn't mean you necessarily have to train it that way, but it gives you the idea of that wobble of the foot and ankle. Every time you get the wobble, it's called noise, and it's pulling and triggering the proprioceptors of the capsule, the ligaments and the tendons to then feed into the central nervous system, somatosensory cortex, and to create a motor response back down. That is a really important part of how we are going to connect to proprioception. Now, to enhance proprioceptive accuracy and perception in our neuropathic clients and patients, one of the best ways to do that is to use kinesiology tape. Tape the ankle and then do the rehab or the exercises for that individual with neuropathy. You got to turn the volume up to the noise for these individuals because everything is kind of muffled and dulled out. So everything that I want you to think about is we're turning the noise up. right? Turn the volume up, put K-tape around the medial and the lateral ankle so we can stimulate all those proprioceptors to help them hear the stimulus again. Okay, that's a great way that I love to do it. Okay, mechanoception now, different than proprioception. Mechanoception is touch or tactile, and this is going to be the skin and the bottom of the feet. We want to access both. This is a big part of why you want to get them out of their shoes. Now, the skin in the bottom of the feet with these different mechanoceptors, you can see the different names of them, Merkel, Ruffini, ending, corpuscles, are sensitive to 2-point discrimination. 2-point discrimination is what Naboso is. Trying to find an insole. I only have a stick, but that's okay, right? The pattern of our texture is stimulating the 2-point discrimination of the Merkel disc. Ruffini ending is skin stretch. So when you are using tape, right, this is another benefit. So you get a 2-for-1 with kinesiology tape, is that you are stretching the skin, you're pulling on the skin through tape, and that is triggering a Ruffini ending. The corpuscles, both the Meissner corpuscles and the Pacinian corpuscles, are going to be sensitive to vibration, okay, to vibration. The vibration is a very important stimulus to the bottom of the feet and into your fascial system, your tissue. In fact, here are interesting foot facts. In fact, 70% of the mechanoceptors in the feet are sensitive to vibration. And from a balance perspective, we use vibration to activate the balance response when we stand and when we walk. So we must be able to feel vibration to accurately maintain dynamic balance. Anything that takes away your perception of vibration is going to contribute to a compromise in balance and stabilization. Shoes, cushion in shoes, is going to be one of those biggest contributors. So this is where, if you're saying, I am giving my neuropathic patients or clients supportive orthopedic diabetic shoes with lots of cushion and a plastizote insole, I get it, it's comfortable, right? We're trying to balance pressure distribution in someone with neuropathy, but at what cost, right? At the cost of disconnecting the perception of vibration and the ground under their feet. So maybe they don't get a callus or an ulcer, but they get a fractured hip, right? So we need to make sure that we're addressing both. So 70% of the nerves in the bottom of the feet are sensitive to vibration. We as trainers, movement therapists, specialists need to think about, how am I allowing sufficient vibration into the bottom of the feet so that my clients and patients can feel the feet when they walk, feel the ground when they walk, feel the impact forces when they walk. Okay. Another interesting fact is that the peak sensitivity of the mechanoceptors in the bottom of the feet is age 40. By the time that individual is 70, they need twice the stimulation, turn the volume up, 2x that volume in order for me to feel and create a response. Okay, so that's another thing when you're thinking about, not only are they neuropathic, but now they're older. So we get this combination of age-related decreased sensitivity of the feet combined with neuropathy. We are starting to make it harder and harder for that individual to maintain their balance when they stand and when they walk. Okay, so that's another reason why we want to make sure that we are thinking about mechanoception. So let's look at how we can start to support these individuals with neuropathies chronically or long-term from a quality of life perspective by thinking about movement quality, movement confidence. So vibration as a mechanoceptive stimulus. Now this could be them walking barefoot on a hardwood floor. You're going to experience vibrations because we experience vibration from ground reaction forces. Another way to bring in vibration is with a whole body vibration platform. I personally have a power plate in my office, in my podiatry office next door. I have a whole body vibration platform, Power Plate, and I will use that with patients as a way to increase their vibratory stimulation as an activation tool. I want this every single day for the patients and for the individuals so that they can make sure that they are bringing in this very powerful stimulus. So here's a study that is looking at elderly individuals with diabetic neuropathy who use whole body vibration to stimulate the feet. And it was compared to if you do whole body vibration plus balance exercises, or just balance exercises, or you have a control. What they saw was a significant improvement in the combination of whole body vibration with balance. So that was kind of the differentiating part, is that when you combine whole body vibration with balance exercises, you got a better improvement than just balance exercises itself. I like to do whole body vibration first, and then I follow it with the balance exercises. So I would do 10 to 15 minutes on the vibration platform, and then I would integrate the balance exercises with the patient or client. Now, the whole body vibration platforms, couple different ways that you can do it. You can even just sit and put your feet on the vibration platform and feel the vibration, and then stand up and carefully execute the balance exercises based off of the programming. Now, if someone does not have a whole body vibration platform, this is where you could use vibration rollers. So I will recommend that to patients or individuals who cannot afford a power plate. A power plate is about $1,500 US. A roller that vibrates is a couple $100 maybe US dollars. And a lot of people are now into the Theraguns and the compression therapy, which if you are going to use that as a stimulus to the bottom of the foot, you want to lightly, very lightly tap the bottom of the foot. You don't want to push into the muscles. This is not a muscular release. This is a neurostimulus. So you lightly use the percussive device. So it's almost tickling the bottom of the foot. Okay, so that's 3 ways that you can bring in, actually no, 4 ways to bring in vibration as a mechanoceptive stimulation as the activation for the individual. Okay, now oftentimes this benefit of whole body vibration on strengthening the foot muscles, right? How can it be used as a mechanism to not just activate the nerves, but actually strengthen the foot muscles? Is that something really powerful happens when you use vibration, specifically the rate at which whole body vibrations are coming into the foot, is that there's what's called a vibratory tonic reflex. There's a vibratory tonic reflex essentially means that as vibration comes in, you're going to want to absorb the vibrations by stiffening and contracting your muscles. We do this exact same thing every time we walk and we strike the ground, and we experience the vibrations from the ground. Is we absorb the energy from the ground, the vibrations from the ground, by creating isometric contractions. That is called the muscle tuning theory. So muscle tuning theory is something that we go into a lot in EBFA's Barefoot Training Specialist certification. Again, this is available on ebfaglobal.com if you're new to EBFA. We go into muscle tuning theory, the power of isometric contractions as a way to load and store the potential energy from the ground. Okay. So here we're seeing, to kind of unpack this a little bit for you, vibration rollers, percussive, whole body vibration, walking on a surface that vibrates like a hardwood floor. Vibrations activate and stimulate the nerves, the circulation. It wakes the foot up. It gets it ready for the balance exercises. Or doing whole body vibration rollers, the percussive, is going to strengthen the foot, because when vibrations enter the body, isometric contractions are the response to absorb the vibrations. So now we have a foot strengthening technique, vibration, and we have an activation technique or benefit through the vibration. Okay, so those are 2 ways that or 2 benefits applications of why I love vibration and why I recommend it to almost all of my patients. Okay. Now, again, we had said that if we put cushion in our shoes, the cushion absorbs the vibration. If the cushion absorbs the vibration, then the foot is not going to be activated as well. Also, the foot muscles will not be as strong because the shoe absorbed the impact. Okay, so here, what is Stephen Robbins, this researcher here, has done a lot of research around footwear, foot materials, surfaces, arch supports, and how they potentially contribute to fall risk. That's really where his interest is. And this is one of his studies that showed that footwear with thicker, soft soles actually contributed to increased instability in men. And the study, again, is essentially saying that if you can't feel the ground because the sole is very thick, it's essentially saying that this is a study demonstrating and supporting that causes a loss of stability. Makes sense, right? You need to feel the ground. You need to feel your feet, okay? Now, outside of vibration, other stimulus that we can bring in, of course, I'm going to talk about texture because that's really everything behind what I focus on in my career. Love vibration, but I also want to be bringing in texture. So texture, which is stimulating the Merkel disc, the SA1 Merkel disc. This is a research study by Hatton, showed that different textures improve balance and stability. They decrease medial lateral sway. There are a lot of research studies in the textured insole space that looks at MS, Parkinson's, diabetic neuropathy, stroke, and showing that the improvement of feeling your feet because you're feeling texture translates to improved balance and stability. Now, this is really the premise behind Naboso is taking texture, these research studies, and putting it into socks and insoles that the neuropathic patient can wear. Sorry, I was showing it in the wrong place. So there's a texture on these socks that they can wear the socks or the insoles in their shoes. So when they walk, they can feel their feet again through this specific stimulus, this specific mechanoceptive stimulus. Now at Naboso, we actually did a pilot. And we did a pilot with 40 individuals with varying types of neuropathy. All types of neuropathy were included, including an HIV neuropathy. And with these 40 individuals, they wore the insoles. This was an insole study. Every single day for 6 weeks, they had to wear it for at least 2 hours. They wore it anytime they walked outside their home. If they didn't leave their home a certain day, they would have to at least wear it 2 hours walking around their home. And this is what we had seen, is that 87% of the neuropathic subjects noticed a positive increase in their foot sensation and their foot awareness. Now, all 40 subjects, I must add, had the negative symptoms. So they all had numbness or tingling. 87% of them noticed an increase in their foot sensation and foot awareness. One of the individuals said, until I tried the insoles, I had no idea that my whole foot was not feeling the ground and the floor when I walked. It was an eye-opener. After wearing the insole, I have more confidence in my steps, even when I'm not wearing the insole. So that's saying that there's this transfer. I think my balance has also improved. I can walk barefoot for a little bit of time with less pain. I'm very pleased, right? So that's awesome. That's great, right? This is showing the benefit that we can provide the neuropathic client that exceeds just take this medication or live with it, or here's some supportive shoes. Now, of those same individuals, 74% of them said that not only did they get an increase in foot sensation, but that improved foot sensation translated to improved balance and stability when walking. This is their perceived improvement in balance and stability. So this individual says, my pedometer on my phone tracks my steps and the differences in stride. I don't know how accurate it is, but always used to have 20 to 30% variance. Now it is typically 0 to 5%, meaning strides are equal, no limping or anything. So that is awesome as far as a change in their balance and stability. Really, really good. And then finally, 97% said that they would recommend it. One said, as an MS patient with foot drop, walking is what I desire to do most. I believe that the insoles have brought to life parts of my feet that were not cooperating. I take more confident steps due to being more foot aware and using the whole foot. I've been walking more and building strength, right? So that's great. That is awesome. So yes, I know I was talking about the Naboso insoles and texture, but I just want you to take this concept and the testimonials from the patients to say, I bet they would say that same thing if you got them barefoot and releasing their feet every day and feeling the ground in a controlled environment, you know, for at least 15 minutes every day. Or you have them take off their shoes and socks and put their feet on a vibration roller or on a whole body vibration platform for 15 minutes, and you did that every day, right? So really, whether it is vibration, it is barefoot, it's going on a hard floor, it is releasing the feet on like a neuroball or something, or it is using the Naboso insoles, you are going to get this connection that happens with those neuropathic individuals. So real quick, Naboso is this SA1 mechanoceptive stimulation tool, okay? You can also say whole body vibration and the vibration rollers to the bottom of the foot are a FA1, FA2 corpuscle stimulation tool, right? So we're talking mechanoception. You combine mechanoception with proprioception. The proprioception is going to be the kinesiology tape. It could be something compressive. It could be an ankle weight. All of that is proprioceptive that you are combining. Okay. Now, to further support what we are doing at Naboso in the space of neuropathies is that we are doing a diabetic neuropathy study at Temple Podiatry School in Pennsylvania. They're doing a textured insole study with diabetic neuropathy. So we will keep you posted on the results of that study. That is IRB controlled. And then the MS Mendel Center, which is in Connecticut in the US, is doing an MS-related neuropathy with our insoles. And that will be another IRB controlled study. And we have one more, it cut off, sorry. We are doing a spinal cord lesion, one with Sloan Kettering, and it's specifically spinal tumors that they treat. Sloan Kettering in the US is one of the largest cancer institutes, and we are speaking to them to also do a chemo-induced neuropathy study as well. So what I want to do is answer any questions that you guys have. I do see some that are coming in so that we can make sure that everybody gets the most out of this webinar. Okay, so Emily asked, could chemo-induced neuropathy be any type of neuropathy, or is it always sensory? So it's going to be sensory. And that is where you're looking at chemo-induced peripheral neuropathy is a toxic associated neuropathy to very specific medications. So certain chemotherapy drugs are more known to create toxicity to the peripheral nerves. Now, what I will have my patients do when I see patients at the same time for this. So again, if you're not within the scope to diagnose or make recommendations, then you can give vague recommendations and say, talk to your oncologist about this or to your medical doctor. Is that if you are doing the chemotherapy medication and you want to prevent the damage to the peripheral nerves, is you can take nerve protective supplements. There is one that is called Medinex. This is an FDA approved supplement for neuropathy. It is essentially methylated B vitamins, Metanex. I will put that in the chat and you can do a little research on it. It is a prescription, but it's FDA approved. So Metanex. The other ones are acetyl L-carnitine, acetyl L-carnitine, and then the other one is R-lipoic acid. So those three are really, really good for nerve protection. Now, for anyone that is getting any sort of neuritises, just because I want to tie that in real quick, is looking at, again, this is, you know, give them the recommendations, CBD and red light. Sorry, I cannot type anymore towards the end of the day. GABA, L-theanine, CBD, both oral and topical, and then red light. So those are for a lot of neuritises that people might experience. And that's for the post-COVID cocktail is I recommend all of these that I just typed in, but especially that red light. Okay, good question. Okay, can people, I'm going to ask another question. Can people muscle wasting diseases and foot drop benefit from the sensory input of Naboso insoles, or would such a condition be implicitly a motor neuropathy? So here's the thing. If you do have a motor neuropathy, let's take Charcot-Marie tooth as an example. So Charcot-Marie tooth is actually a combination one. It's a motor sensory combination. What you want to think about here is that despite the muscle wasting and the muscle weakness that is inherent with motor neuropathies, is we need to increase the perception of how that foot is striking the ground. Even if someone has foot drop, I still want them to use the Naboso insoles and get barefoot stimulation and release the feet and have their feet on vibration platforms, because I am trying to bring perception to this unstable environment. I tell them it's not going to reverse the foot drop, right? That's not what we're saying that any of these things are going to do. But if I can bring a little bit more control and awareness and coordination as the foot strikes the ground to a foot that has foot drop or motor or muscle wasting, then that is how we want to look at these tools. Okay, so it's going to try to help those individuals versus saying any of the stuff that I'm talking about is for purely sensory neuropathy. That's not true, right? We want it to be for both sensory and motor. Okay. Emily, I answered your question about the prophylactic mediating chemo-induced neuropathy. That would be the medications that I got. Okay, perfect. Emily, we are totally like one step ahead of each other. Someone asked, can idiopathic neuropathy be a signal for prediabetes? So this is a part that I didn't go too deep in with the neuropathies. We do have another neuropathy webinar that I do go into it on the EBFA YouTube channel. So just note that, where I go heavy into all the different types of neuropathies. But here's the thing with diabetic neuropathy is classically a stocking glove neuropathy pattern, which means it's going to be both feet at the same time. So both feet as distal as you can, that is how it starts. So if someone is saying, I have tingling in all my toes, little worse at night, both feet, right? And it's kind of coming a little bit more into the toes, but both feet, same place, always worse at night, and just kind of that's their sensation, right? That could be starting to say that could be pre-diabetes, because pre-diabetes is always bilateral and symmetrical. Okay, and all neuropathies are worse at night. So just as an FYI. Okay, now idiopathic neuropathies, a lot of idiopathic neuropathies are unilateral. They're just one foot, and the pattern is not as stocking glove as a diabetic. So that's where when you also start asking about neuropathies, is if someone says, oh, I have neuropathy, ask them the type, but then also say, is it bilateral? Is it one leg? Is it the toes? Like what part of the foot is the neuropathic symptom, and is it positive or negative? right? That's how we want to start strengthening the questions that we ask. If a nerve conduction study is performed and the sural nerve is functioning, can neuropathy still be experienced by the client? Another great question. Okay. So what this individual was asking was actually starting to differentiate between small nerve and large nerve, or small fiber and large fiber. So nerve conduction tests, NCVs and EMGs. So typically you order an EMG and NCV at the same time, but an NCV is really testing large nerves. So they're going to be larger. Sural nerve is a large nerve, okay? The mechanoceptors in the bottom of the feet are small fiber. The only way that you can test a small fiber is by doing a biopsy. So you have to biopsy, and then you actually count the number of fibers under a microscope, the nerve fibers. So very different. I take NCVs and EMG results very with a grain of salt. I actually very seldom order them, because if someone comes to me and says, oh, I have burning along kind of where the sural nerve is, or kind of the bottom of the foot, or I'm starting to get like this spasticity in a toe, I know that it is a nerve dysfunction, a nerve disruption. I don't need to do an NCV or an EMG to confirm that, because these are very uncomfortable tests for patients that I don't want to put them through it. I understand that it is a neuritis or a neuropathy of some sort, and then I address it. So yes, for your question, can someone have a sural nerve that tests normal and then still have a neuropathy? Yes, my suspicion would be that they have small fiber neuropathy. Okay. Guy, hi, how are you? Would you say that the Perform insole is more recommended for people with positive neuropathic symptoms, where the neuro insoles would be more for negative neuropathic symptoms? So not necessarily. So, oops, let me go back. So here, Guy was asking about the different insoles that we have. The red one is Perform, the gray is Neuro, the blue is Activation. The one that we recommend for all neuropathic individuals is the gray. It's called Neuro, so neuropathy, neuro, just kind of think of it and put it together. Now, could they use the other ones? Absolutely. The ones that we use in our research studies are the neuro. In the US, we're going through the FDA process for the gray one, for the neuro one. It is a higher level of stimulation compared to the other two, so that's where we recommend it. Now, if someone has painful neuropathy and not numbness, could they use Naboso? Yes. And now this is what your strategy is you are trying to desensitize the patient or the foot. Okay, by bringing in a stimulus to someone with a painful stimulus, you're trying to kind of trick the brain, because the brain can only kind of focus on one stimulus at a time, and you're trying to essentially trick it or override it, distract it, right? That's how a lot of TENS units kind of distract from pain, is they're trying to override the system. So that's where we have had some individuals say that their painful symptoms decreased with the Naboso insoles. Okay, so when we recommend them, we say get the gray or use the socks. Of course, they can do the others, but again, I would always go towards that gray, just to keep it easier. Neuroneuropathy, put it together, it's our medical grade one. Okay, great question. Okay, any other questions? Sarah says that she has the gray ones and she doesn't have neuropathy or pain, but she loves to use the gray ones and the socks. Yes, so it's not just, you don't have to have neuropathy or MS or Parkinson's to use the gray ones, but that's the one that we guide people to, just to give it, to make it a little bit easier, especially if you're dealing with someone with neuropathy and comorbidities and maybe they're older. We just want it super, super simple, right? Just get the gray. Don't even give it a name. Just go online and get the gray one. Or if you sell them in your office, go with the gray, right? And you just make it really kind of simple for those individuals, because it increases in level of stimulation. Okay. Last thing that I want to add on there is if these individuals are using them every single day, then you want to alternate them. So if every single day you are wearing Naboso insoles, we need to avoid kind of this tuning out, right? If you have this constant stimulus to the nervous system, you got to mix it up. Otherwise, the nervous system is going to acclimate and tune it out. In the neurosensory specialist course that we're doing this weekend, so if you're interested, do check us out. It is on the Naboso website to sign up for that. Just hit discover and you'll actually see it. It is recorded. Neurosensory specialist happening this Saturday. So definitely sign up for that. We go into what's called sensory gating, and part of sensory gating is this filtering out of stimulation, and we are trying to override that so the neuropathic individual can keep feeling their feet. We don't want them to tune out their feet, so we got to mix up the insoles so that they stay kind of guessing and tuned into that stimulus. So just kind of take that also, and we go into that much more in that training. That's called textured variability. Okay. Wonderful. Great. Thank you guys so much. Do stay tuned for future webinars that we will be having. I hope that I see some of you on Saturday's training. If you cannot do Saturday's training, then we will be offering it soon again. And I will be traveling to Australia soon, actually the end of the summer, our summer. Wait, so it's going to be your winter. End of your winter, we're going to be hosting some trainings in Australia. So do check that out so we can get you registered and saving that date. Thank you all so much. Have an awesome day if it is the morning for you. Otherwise, have an awesome night for everyone else. Take care.